Hello, good evening, everyone. Good evening. You're welcome again to our webinars on Skin NTDs. My mind is all in WCD because that's where we're heading to next. Thank you very much for joining. Today we're going to be discussing Noma and Mpox. And Dr. Ife Adetula is here with us to discuss Noma, and Dr. Seb Oiwo will be talking about Mpox. But he's on the road, so he's always on the move. So if he doesn't make it, then I'll take the the course on Mpox. So thank you everyone for joining, and let me just see if any of our other panelists are here, but we'll wait till about 5 minutes past 5 to start to give room for other people to join in. Okay, so just give us a few more minutes before we go ahead. Let me enable Dr. Adetola to be a panelist.
Good evening, Dr. Cole. Good evening, everyone.
Good evening, Dr. Abdullahi. Thank you very much for always being there for us. So I hope everyone who has been following the webinar has learned quite a bit about skin neglected tropical diseases. We started this series in February, and we've been able to cover most of the skin NTDs. I think the only one we haven't done, the WHO recognized skin NTDs. I think the only one that we haven't discussed is snake bite envenoming. Some people say, oh, it's not a skin NTD. But apart from that one, we have covered, pretty much all the skin NTDs. And all the previous webinars are on YouTube, so you can actually watch them on YouTube if you missed out on any of them. And it's a resource that will just be there, And we always say that there are so many resources on skin NTDs for health workers if you're interested. The WHO has a series of online lectures, self-paced lectures on the various NTDs, including skin NTDs, that are free. And you can always go to the open WHO website to, go through those courses. So that's there. They also have a skin NTD app, that's the WHO, that can help with aiding the diagnosis where you're not sure. And we are also working on an app that will also help with reporting, so you can have access to a dermatologist to assist you with the diagnosis and all. So thank you very much. Let's just wait for 1 or 2 more minutes and then we'll start. Thank you. Good evening again, everyone, and you're most welcome again to our Skin NTDs webinar series. We're discussing 2 NTDs, or one is no longer an NTD. It's now, one of the star diseases in the world, but Noma is a neglected tropical disease. And that's because it's not fully recognized yet by the WHO, even though it has all the features of an NTD, that it affects the poorest of the poor, and it's only found in very remote poor communities where there is, lack of access to basic amenities and we really feel that it should be addressed, even though it's not a WHO recommended. And Nigeria is one country where we have quite a number of cases of Noma. And in fact, most of the research publications that we have seen on Noma are from Nigeria, particularly the northern part of Nigeria. And we want to be able to sensitize health workers about Noma because it's one of those diseases that are best treated early, because at the late stages, like most NTDs, it results in very severe deformities and disabilities that are often, almost irreversible. So we're going to have an expert talk about Noma, and I will just ask if Dr. Oiwo can introduce our first speaker if he's available. And then Dr. Adetola, I think you can share your slides now. If you have slides to share, you can go ahead and do that. Dr. Oiwo, are you online? I know that you're still en route to Abuja. Whether you can just speak about Dr. Adetola. I know you work closely together, and we're all online activists. So I see Dr. Adetola quite often on Twitter trying to make a case for Noma, and that's very noble of him, to be able to continually engage, the powers that be and say, please don't forget about Noma, this very, very debilitating NTD. Okay, if Dr. Oiwo is not available yet, probably due to network issues, then I will just ask Dr. Adetola to please start his presentation. So I know that he is a dental surgeon, and he's also a member of the NMA NTDs committee. So I'm sure he has a wealth of experience to share with us in those two capacities. So thank you very much, Dr. Adetola. You're most welcome. So I think he's just sharing his presentation. Just give a moment. Please remember that if you have questions, comments, you can always put them in the Q&A section of the Zoom webinar, and they'll be answered after the presentation. Dr. Adetola, are you there?
Yes, I'm with you. Thank you very much for the introduction. I'm trying to share my slides.
Okay.
Yeah, I'm coming. Good evening, everyone. I'm happy to be here. Of course, I've joined various sessions, and indeed I've learned a lot of things, and I'm grateful for this opportunity extended to me. I'm a dental surgeon, and I have more interest in. Please, am I audible?
Yes, you are very audible, but we can't see your slides yet, though. But we can hear you loud and clear.
Yes, that's what I'm trying to do while trying to introduce myself. I'm coming. Let me see if I can share from documents. I have it here. I'm sorry, please. Yeah. All right. Okay.
All right.
Good. So good evening, everyone. I think the introduction has been made, and there is nothing else to add to it. I'm a dentist. I have more interest in community dentistry, and I'm just trying to do some work on Noma with this organization, Zero Noma Initiative. Next slide, please. Next slide, ma'am. And in this brief discussion, for me, it's just a brief discussion. Next slide, ma'am. I want to follow this roadmap briefly to look at Noma from the perspective of a community dentist. Of course, like it has been mentioned, we've had a number of weeks having discussion around neglected tropical diseases. So probably I may not even take more time there. Then furthermore, I will now look at how Noma, I will now look at Noma as an NTD in general, then particularly Skin NTD. After that, I will pick one or two things on what is expected of participants in the room. At least we have about 95, okay, more than 100 people on this discussion, which definitely means that we have people in different parts of Nigeria. So what is expected of us after this discussion? I will say one or two things about the approach we are taking from Zero Noma Initiative, and I'll draw some general thoughts, and that will be all. Next slide, ma'am. So Noma, it derives its name from a Greek word which means to devour. And when you take a look at a patient, you agree that it is a great, indeed, it's a devourer. Skin, bone. Sometimes people had instances where patient had lost eyeball. So that word is a very perfect word. And of course, it had been named the face of poverty. I think I should also say at this point that I deliberately do the presentation in a way that it won't be the high term medical word, because the flyer I saw, made it known that, okay, doctors, community health workers, so I want to try as much as possible to take everybody along. So furthermore, Noma, I look at it as a journey from the gum to the skin. And when I say the gum, that is this pinkish stuff, soft tissue in the mouth that goes around the teeth. The way Noma starts is that you have this deposit around the teeth. Of course, that physical presence there causes some irritation, which we call, irritation, inflammation, gingivitis, and all the itis. So from the gum, it goes to other structures that support the teeth, which in dentistry we call periodontium. So when they are inflamed, periodontitis. From there, the old word for the mouth is stomatodium. So stomatitis, because what happens is bacteria build up in the plaque combined with immune deficiency, which can come from maybe malnutrition. In some normal patients, we've even seen HIV. So the bacteria load is building up on one side, and on the other side, the immune system is reduced. So from the gum to the periodontium, and then you now have the soft tissue around it, around that area of infection, and the process continues. We also know the risk factors, malnutrition, like I mentioned, and we know, I was reading a report 2 days ago, and in that report, they were talking about they were reading out some statistics from northeastern part of Nigeria, and it's a cause of concern. Of course, it's preventable, and it is non-contagious. Of course, it's a disease that's of public health interest. And the factors that make it occur are also things that are of interest to global health. Next slide, please. Next slide. So those are just like the basic way of making an entrance into what Noma is. Of course, commonly we see it at age 2 to 6. When I say at age 2 to 6, is the time it occurs. And there is no sexual predilection. When you have a child where all these risk factors are available, the child is at risk. WHO says we have a global incidence of 140,000 annual cases. And from there, of course, when I mention survival here, I have a picture, I think in the next slide, to give a pictorial description of the different stages, and from there I can make some more distinct to it, some more sense from it. Then in stage 3, okay, 70 to 90% mortality rate. That's when you have the infection, very high infection, sepsis that require urgent attention. If not, you can see a life ebbing away right under your face. And then survivors means those who, some people may be able to make it to the hospital, some people may use self-prescription at home. So survivors are those who are able to skip through the infective phase, the septic phase. And depending on this part of the face that has a defect, the functional disability are there And there's a particular study that showed that a patient had Noma at maybe 4 years, and he lived with it for almost 6 decades, 60 years. So you can imagine the limitation in mouth opening, difficulty in speech, the affectation of feeding, definitely child, while growing up, he won't be able to mix with his friends and colleagues. Next slide, please. And in our Nigerian parlance, I think because of the malnutrition and the other risk factors, we have more in the north. Virtually all the cases I've seen had been from northwest, north central, and northeast. The last case was still from Kano, that one of our volunteers we saw. So if you can just take a look at, this spectrum, and this is, by presentation, one of the aims of this webinar is that we will be able to pick up cases. So the first stage, if you look at that first one, necrotizing ulcerative gingivitis, the plaque had built up. Looking at this patient, you may not be able to say anything from outside because it's still at the early stage. By the time you are getting to edema, remember I made mention that you now have contiguous area from the gum. So on the skin, the infection is going on. So what they will usually say is, that this child face is swollen up. In fairness, as somebody has not eaten, instead you should be coming to the hospital. There could be clash of interest. Remember, these people also stay in areas that are far from any health facility. So, but by the time the child is now getting, the process is now getting to stage 3. I think, let me even mention at this point that the patients in stages 3, 4, and 5, they were not textbook cases. Rather, they were patients seen live and direct, because we felt we shouldn't just bring something from textbook that people may not say. Rather, it should be something you'll be familiar, that could be familiar with. So it is in our environment. Also, we also have this late health-seeking behavior. So it means stage 1, stage 2 may not commonly be seen. But as stage 3, the child who was a little bit active is now sluggish, not eating. So the parent may at that point may be wondering what is happening with this boy. Of course, they may say, okay, let us make an attempt. So you can see on that stage 3, this big scab. That's from the area where the child initially had that swelling. And then fortunately, we heard about this case early. We tried to rally around, tried to do the debridement, and then stage 5, where we have the sequelae. Remember, I mentioned that it can affect any part of the face. Any part of the face. If you look at the way we describe, we divide the face into 3. The upper third from the hairline to maybe somewhere around the junction of the frontal bone. The middle third is somewhere between this frontal bone, in between the 2 eyes, to somewhere under your nose. That's the middle third. And the lower third is from this area down. So commonly is the lower 2 thirds that are affected, but in my number of years of working around this disease, I've seen affecting everything. So commonly the middle and the lower, sometimes the lower. I've seen a particular case where it caused blindness, and on the forehead, you now see a sign of resolving cellulitis. If maybe some brain waves are done for that child, I won't be surprised if you can find something up there, but it can present affecting any of these 3 zones. Next slide, please. And so this is how one of the ways it could present. Next slide, please. And when you see it as maybe stage 3, it's an infection case, which means antibiotics, pain relief, high nutrition management, containing protein. Of course, if you have adequate lab, you can do basic checks to pick up derangements. Furthermore, still looking at the presentation, this child, actually that's my hand in the glove, and I was just trying to say, in every case of Noma, you also see malnutrition, and you can see it classic there. This woman, what happened was that when he had the defect, it made a space available so that by the time the teeth was that particular tooth was growing, the way the teeth grow in the mouth is in the neutral zone between the cheek and the tongue. So when one of the soft tissue is missing, nature abhors vacuum, the teeth flared out. Next slide, please. So you can see many. I remember the particular case that the whole middle third, just imagine the skin on the whole middle third, everything gone. And what you're looking at is just bare bone, necrotic anyway. So with this destruction comes, the defect. These 4 pictures are the same boy. Initially, when we were seeing the boy, he was cooperative, but the time came when we went visiting, thanks to one of our volunteers. The boy, maybe less than 5, he will be like 6, 7 now. He has become, to be aware of himself. So the person who smiles at us, you can see him looking down right there. So stigma, So these are some of the presentations you can see. And when we see, we can easily say, okay, this is normal because it's more of a clinical diagnosis. Next slide, please. It's more of a clinical diagnosis, or just that the management may now involve maybe laboratory tests for anemia, for if there is HIV and stuff like that. We have lost some time earlier, and also we've also discussed extensively about NTDs. So I won't take more time here. Next slide, ma. Next slide. So diagnosis of Noma is a spot diagnosis, but to manage objectively, it may ever require some lab. Next slide, please. May ever require some lab tests. But when you say Noma case, it's a spot diagnosis. So I've made a brief entry into what Noma is. I believe some of us will have seen it before, and for those who have seen for the first time, I've tried as much as possible to make it simple and straightforward. Noma as an NTD, the face of poverty. A patient at stage 3, if you didn't do anything, it has a chance of 70-90% of death, high mortality. Cases seen often does require awareness. This we see more in Africa, so that there is a geographical area called Noma belt. So that's to tell us how much of course, the risk factors. Most respectfully, we know what the economy is saying in this current day Nigeria, and it definitely have trickle effects. So of course it's preventable by the time you address some of the risk factors: water, sanitation, and hygiene. And just as I've put it there, plaque remover. If you remember that spectrum, the first picture, plaque. I did a little thinking around the risk factors, and I felt it may be a little bit difficult to address poverty in entirety. But if something can be done about oral hygiene, well, at least the chance of reducing occurrence may be high. Such plaque removal is a public health measure and a very potent preventive measure. So another way Noma is an entity is also the fact that there is knowledge gap. Next slide, please. And of course, funding gap. I think it was in 2018. Next slide, please. It was in 2018 that the former now, Minister of Health, was saying that we do not have an official figure on Noma. And that's part of what to deal with. So I think the next session I'm moving to now is I've established what Noma is, I've shared some personal experience, and I've also shown how that it meets some of the criteria that WHO set for NTDs. And it's also a good point to mention that significant effort have been put in place to see the addition of Noma to NTD. Hopefully, maybe before the year runs out or next year, it will be announced. So the next slide now is looking at how Noma is a skin disease and also a skin NTD. I started by saying that Noma is a journey from the gum to anywhere on the face. And if you can appreciate this picture very well, we can see this huge defect. This was after the debridement had been done for the necrotic tissue. Of course, it's a serial debridement. You dress with, there are different postulates, but you dress, people use hydrogen peroxide, honey dressing, or at least you dress, daily dressing that first week, so that tissues can die off on their own. But looking at this patient, you can see the fibers of the orbicularis oculi in the lower lid. You know, we can see the necrotic bone. We can see, I mean, of course, all the buccinator muscles, everything gone. So it's a journey from the gum to the skin, and because of that, we can consider it a skin NTD. Currently, in addition to other 3 diseases, currently I was reading a report from NLR saying that they've currently acknowledged Noma as a skin disease, so it worth it. Next slide, please. There's a particular case that the first place where they even, remember I mentioned that stage 3, stage 4, stage 5 are the phases where they commonly present. Okay, so NLR, this is identifying Noma as a skin disease and as a creative means of which people can use. They did the form of this game card, which people can use. I mean, it's knowledge-based, and they also developed an app, you know, this skin app, which also acknowledged Noma. So it's a skin disease. It affects the skin, causing, I mean, issues. Of course, the function of the skin are well known. I'm not an authority in that aspect, so let me keep my mouth shut. But we know that Noma starts from the gum, affects the skin, and of course the function in the areas are affected. Next slide, please. Next slide. So I wanted to, okay, this case study, this is clinically a case of Noma. And if we cast our mind back to the spectrum, this is a sequelae. It's a 25-year-old who presented first at a dermatology clinic. You know, so as dermatologist, as community health worker, it is, and that, I mean, we can see any of these patients anywhere. We can see, and that's because the different part of the body, they work together. For some other people, their complaint may be because there's a particular patient. Okay, good. This patient, this second patient, of course, the defect on the face, on the face is of aesthetic concern. But this person came down, his complaint was that the mouth couldn't open, severe trismus. But for this patient that's of interest, the first place where I was saying was dermatology clinic. So it means we also have a role to play in creating awareness of skin diseases, skin NTDs, for which Noma is part of it. Like I was, so at stage 5, okay, the defect it was a concern to her, some trismus, limitation in mouth opening, and of course, one may want to wonder if this person is going to eat, where will she put the food? Is it on the side or the original opening? But fortunately, we were able to link up with some of our partners, and they tried to do some surgical rehabilitation for the patient. Next slide, please. Next slide. So for us, we are a registered organization, and basically we are taking a preventive approach to Noma. Our target is 0 cases of Noma, 0 death, 0 stigma. Taken from the issue of stigma, I can't imagine myself having that kind of signature defect on my face. But there are people who have it, so we try to create awareness, linking them with our partners. And it's a possible point at which we can see them either in dermatology clinic or when we go for awareness. Of course, also 0 death. When there is sepsis, and if treatment is not initiated immediately, a life can ebb away. So at that point, we try to assist, humanitarian assistance. So awareness, collaboration, outreaches, and those are some of the things we do. And of course, me coming on board, and of course, subsequent working together as a form of collaboration. Next slide, please. And basically, we don't work in the theater. Rather, we look for collaborations. Next slide, ma, that can work so that we can identify cases and help patients out. We are currently working with an organization focusing on nutrition because it's also part of the risk factor. So, call to action. 1, the place of identifying cases and reporting. I know of the Skin NTD app. We're trying to work on our own Noma alert, but with the look of things, 1 or 2 issues, but then it's part of things we are doing. It's also good to be able to differentiate it from cleft, which is the closest ally. It's differential now. Everybody knows cleft is congenital, whereas Noma is not. And of course, creating awareness. By the time we create the awareness, of course, like I mentioned, that it will be at a later stage. But by the time we create awareness and also amplify the position of Noma, we are all together playing our role in addressing skin NTD. Next slide, ma'am. So awareness, advocacy. So as I begin to round up my thoughts, I wrote it here that we already have a significant number of NTDs in our domain. Now that the addition of Noma is imminent, it means for us NTD people, for us dermatologists, is a call for us to give more attention to NTDs and possibly to be at the forefront. And then this is also another opportunity for oral health integration into general health issues. That's because a disease from a part of the body can end up in another part. I wrote it there that skin diseases in another part of the body can be masked. But what about the face? You know, next slide, ma'am. Next slide. So I wrote it here that most likely they will present at irreversible stages. I mean, that's places where we likely see them either in the community, maybe in emergencies, or even our clinic. You know, but when we amplify our efforts, the final stage we are calculating is that we don't even want cases to happen because in our climate we don't have adequate materials to address them. So whatever we can do so that cases do not occur is worth it. Next slide. Next slide. So I think I decided to put this picture there to show that this Noma affecting the skin. And of course, when you see Noma case, you can always see the indices of malnutrition, the prominent shoulder blade in this patient. Next slide. And next slide, ma'am. I think we are still in the mood of celebration, so it's not out of it to say happy December to people that are celebrating. Next slide. I think these are my references. Thank you very much.
Thank you very much, Dr. Adetola. That was a really great presentation. And the pictures, in fact, the pictures were very, very graphic. At some points, even I was a little bit perturbed by the pictures. And, you know, more so that this is very common in children, which, you know, is really heartbreaking that they have to go through this kind of terrible disease. And the reason why we're featuring it on the Skin NTDs webinar training is because the first signs will be on the skin. Before the person opens their mouth, the features of Noma will be seen on the skin. And that's why, even though it starts from the gum, the skin is usually the ambassador, the one that makes it visible for people to see. And a lot of cases of Noma will actually present first in a dermatology clinic or a skin clinic or for a skin-related concern. And that's why we feel that people need to be aware of it and know what it is and how to do. But there are some questions, and I would like us to just take your questions first before we go to the next presentation so that we follow the flow. But my question is the organisms responsible for Noma. And you didn't really discuss first-line treatment, or other than referral, what can a person do in a community setting when they see a patient with Noma? What are the key points, things that they should do other than referral and try to educate about nutrition, which you mentioned? What else can they do as a form of primary or first aid or primary care?
Okay.
Thank you.
Okay, thank you, ma. I'm imagining myself that I'm in a community where there is no phone, no anything. If I have a normal case, what will I do? For these patients, some of them may not be able to tolerate anything per hour, because at that point, you want to reduce the disease burden, in this case, through drugs. So if that will mean that I mean, maybe if there's a PXC close by that can give injection before you transport. I'm trying to be as practical as possible. But if there is none, there may be a need to devise maybe a means of, even if a child cannot eat, there could still be a way to make him get a drug. I don't want to, I'm trying to say, okay, if I'm the community, what will I do? Because two things. One, the disease burden, the infection, the body of the infection, which in an ideal setting, you do the debridement, you give antibiotics and pain relief, you hydrate. So you may now say, okay, in that setting, how can I improvise any of these three? And after which you get close to a place where they can set up IV line and administer drug for this patient. So depending on whatever setting you find yourself, and I think that still brings us to a PXC setting. I've been to a PXC setting. At least they can give injection. They can they couldn't set up line, but at least they can give injection. So whatever first line antibiotic that is available for that child at that point can be given, because the patient won't be able to tolerate anything through the mouth. I even forgot to add that you have this fetid odor, of course, necrotic tissues, and so I think that's a first line in a most practical way that can be done in an environment where there is even no network to call anybody. Somebody said, what's the meaning of, okay, Moses, he said, I should have blindfolded the patient. Oh, apology for that. Full meaning of WASH, water, sanitation, and hygiene, is an acronym to, combining water, sanitation, and hygiene. Are there specific organisms implicated from culture? It's an organism that is an infection that is involving multi-organisms. What has been discovered is, now, WASH deals with source of water supply. So it's a form of a multibacterial setting, and he's trying to say etiology or to isolate the real organism, but many studies that have been done yet not conclusive. But maybe with this new microbiology technique, maybe something can come out of it. After healing, how can the opening part of the teeth and gum be covered up, looking at the degree of damage? Thank you very much. I mentioned that we have partners, MSF particularly, they do different kind of surgery for patients. So I'm not a surgeon. I didn't mean I was a surgeon. Maybe I would have been talking about A flap, a standard flap, 4F flap, but it doesn't look as if this is the kind of setting for that. So I'm sorry. What are the possible differentials? Commonly, like I mentioned, cleft. But the way we know cleft is that the patient comes with it, and cleft is predictable, either in the central, involving the palate. But Noma, you have, you look, even looking at the pictures I showed you, you saw many organisms, many patterns. Other differentials, we're also in an environment where people don't present early. So when you have a fungating squamous cell carcinoma of the lip, it can go anywhere. It can actually look like it. I think that was the case we saw at the time that I felt, look, even though we are looking for cases of Noma, we shouldn't mix Noma for squamous cell carcinoma. But that kind of squamous cell carcinoma will definitely be like maybe stage 4. All the lips gone.
Yes, and sorry to cut you, Dr. Adetula. Someone was actually asking that the way it looks, is it not a cancer? It looks so much like squamous cell cancer of, the skin and soft tissue, but it's actually not cancerous. But I guess a biopsy is what would be it would be very important to biopsy, right? To rule out a possible cancer in most cases. But there are probably some features that will let you know that this is not a cancer.
Okay, thank you, Ma. I think the other thing that I should probably add is that this, the plaque is there in the mouth for a long time. The duration between the time the thing swells up and the time it becomes plaque necrotic is within 2 weeks. No cancer will do that. So remember I mentioned that it's like a clinical diagnosis. They will tell you 2 days ago,
I see.
He didn't eat food, he was salivating, and in fact, it is that sudden change that will make them stand up and be running. So it is not, so that's how we can differentiate it from cancer.
Has a short clinical history or clinical course.
In fact, another reason why we don't, in addition to the fact that until the sudden change temperature, not eating, Malay. I mean, that's why. So they keep all these things to themselves at home. In addition to the stigma, I think the last patient we saw, the father couldn't even carry the boy. I mean, the father of the patient. So the stigma is not only on the patient, but also caregivers. Apart from spot diagnosis, what is the causative organism? Like I mentioned, is bacteria, multibacteria. Plaque in the mouth is a multi-complex. And that's, remember I mentioned that plaque removal is a potential public health and preventive measure. So clean your mouth. And of course, by the time we're going to such an environment, part of the thing we tell people is brush your teeth. You don't even need brush. I mean, get chewing stick, so.
Yes, I was going to say that, for rural communities where they may not, be used to or have access to toothpaste and, things like that, there are other options. And even salt, someone said, common saline gargle can be useful in prevention. What do you think about that? Just salt water to clean the mouth, that is.
Let me break it down into, let me be a little bit practical. The reason why we use toothbrush is the mechanical dislodgement of plaque. So if, what do you call it, chewing stick, we do it, fine. In addition, there's even a research study that was done that looked at some trees that people usually use that they use for chewing stick. And they felt some of the trace elements that they package in close-up were also found in these trees. So public health principle determines that you use appropriate technology which the people can afford. So let them use whatever is commonly available in the environment. Use of salt. Salt has antibacterial properties. So people are using it, I don't want to say ignorantly, or let's say people are using it without understanding of the real reason, as it were. They were not doing harm to themselves. So that's how I can approach it. Are there cosmetological repairs? Yes, there are surgeries done. Sorry, I should have probably added some pictures of before and after. And that's what we take when we go to do awareness to say, because somebody had lived with a defect for 20 years. He has acclimatized. So, a major issue with this kind of people is you need to do extra work to convince. So by the time we go to them with pictures of before and after, you see the light in their eyes, let's go. So there are surgeries. Currently, they do it in Sokoto, but a center is springing up in Abuja. But Abuja, anybody coming from, say, Taraba to Abuja is still significant distance. Nevertheless, those are the two centers doing it for free. I hope this kind of webinars continue. Okay, this is a suggestion. Thank you. You mentioned malnutrition as a determining factor. Are there nutritional deficiencies implicated? Absolutely, yes. That's why I brought that picture, the penultimate picture, where I was showing, when you see a normal patient, all the indices of malnutrition from head to toe, the fluffy hair, the, shoulder blade, prominent shoulder blade, by the time you do the mid-upper arm circumference, you can see. So nutritional deficiencies implicated. Deficiencies, yes. Sorry, I misunderstood the question. Largely, if you look at their nutritional pattern, they take more of carbohydrate. So nutrition deficiencies, protein missing, vitamin missing. And you see, part of what we do is to make them realize that in your environment, you have sources of all these groups of food. So nutritional deficiencies, yes. What's definitive causative organism? I think I've answered that. If none, what are the commonly cultured organisms? Is multibacteria. I mentioned Necrophorum, Actinomycetes. There are actually a lot of them, but that we've been seeing. Besides identifying case, what are the practical steps in prevention? In prevention, toothbrushing. In prevention, clean water. If situation happens that you are sharing water source with animal, there are local, homemade system of purifying water, that can be used. Then we've also seen instances. Remember, I mentioned that there's a short, you have the swelling
All right, I think Dr. Adetola went off, probably network. Let's see if he'll come back soon. Network has been a bit shaky today. We have so many questions. I think he's back now. So we just have like 3 or 4 more minutes for the questions so that we can go to the next presentation. Doc, are you back?
Yes, I'm back. I'm sorry for that
Okay.
interruption.
No problem.
So I think that
I was saying just if we can just have maybe 3 or 4 more minutes to answer questions so we can go to the next presentation.
Yes, that's why I'm trying to hurry up.
All right, thank you.
Poverty alone. Poverty itself predisposes you to many other things: malnutrition, poor water source, etc. Can it be seen in adults? In my own experience, it will happen in children, or because nothing was done, you can now see it in an adult. Where was a particular patient we saw in Lagos like that, who had been carrying it for almost 30 years. So the onset is not in adults, or rather, people carry the stigma till adulthood. Any major to pregnant women with Noma, by the time you are seeing a pregnant woman with Noma, it's likely the defect is to do corrective surgery. Most fearful complication of Noma. I mentioned that I've seen most fearful complication, death. I've also seen instances where there was blindness. Please, did you, causative organism, I've mentioned that, preventive, I've mentioned that, broad spectrum. I think you can start with that. Of course, probably that's what you, empirically, what you can start with. By the time you do MCS, you can pick whatever is sensitive, you change to it. Why does Noma have a position for the face? I think this is a good question. I made mention, I always believe that a child is malnourished, is immunodeficient, but the plaque and calculus in the mouth makes it the gum a nidus where the process can start. You see, that plaque and calculus, I remember those days before we start to kit up, somebody was doing the treatment, scaling, flipping up, accidentally it fell on the eye, and within maybe 24 hours, the eye turned red. So a plaque that you flick up contains loads of bacteria. So when you have bacterial load, of course, it will start from somewhere, which is the gum, and progress. I think I've answered that. Diagnostic testing. At that diagnostic testing, let me say no, or rather that checkup, people should clean their mouth at home, occasional checkup, it can pick some of these things up, and you can do scaling and polishing. And probably it's also a good time to advocate the place of oral health in PXCs, where some of these things can be picked up and addressed. Is it contagious? I've answered no. For the presentation, mucormycosis. Mucormycosis, it is not another name for Noma. Mucormycosis is a fungal infection. Noma is bacterial. How do I differentiate? Noma, you will see there'll be the swelling, and the parent will tell you, but there'll be a very short period from the time you have that swelling and the time it becomes black, necrotic. But mucormycosis, most fungal infections, they are there for a significant period of time that you bombard it with antifungal drug, bombard again and again. So in that instances, it's different. But for Noma, by the time you remove the necrotic tissue, you have this beefy red. And by the time you do open dressing, it will definitely heal faster than mucormycosis. Thank you for the webinar. Magnitude of Noma in other African countries. Where I mentioned this issue of Noma belt. Sorry, I didn't add the diagram to it. It was a stretch of country from Senegal to Ethiopia. WHO says 140,000 cases annually, but that figure was given more than 25 years ago. I believe if we check our methodology again and check again, it's either it has increased or decreased, but significantly there has been change in the risk factors, the economic factors, and it's possible it has affected the cases. I think I've run through the questions. Some of them are repetitions. And once again, let me really appreciate the Nigeria Dermatology Association for this privilege. I thank you very much.
Thank you so much, Dr. Adetola. This has been very, very enlightening. And now I know a lot of people here would know about Noma, and if they do see cases, they'll be able to know that, okay, urgent referral, broad spectrum antibiotics, and in the communities, prevention is key. We want to prevent Noma with adequate nutrition for children and then good oral hygiene. So those are the two main things, right, that we can do to prevent Noma. Sorry?
There are organizations. So I just want to add an information with you.
Okay. Hello. So sorry, the network. But you can always type it in the Q&A. So that, hello? We didn't hear you. The network was. Hello?
Okay, I said there are organizations that are helping. We know that a normal child patient is poor and issue of financing. But if cases are seen, we can be contacted. We have some partners who can help. And like Sokoto, they are also trying, the treatment in Sokoto is largely free. It's just for people to have this information and follow it and apply it. But if people don't want to take that stress, if any patient is seen, which we hope that we'll be cognizant of them right now, we can be called upon and we help through any of our channels so that there won't be another mortality. And for those with stigma, we can help them get surgery and at least, even if not 100%, 80% is a fair deal and better quality of life.
Okay, thank you so much. Thank you very, very much. Please maybe we can put your email in the chat box so that if people have want to contact you, they can do so. Thank you so much. So, Dr. Oiwo, are you around now? Hello.
Yes, I am, Dr. Cole.
Okay, that's great. Great, awesome. So we're going to quickly take the second presentation, which is Mpox. So Mpox is not an NTD, at least it's no longer, we can't really say it's an NTD anymore since it took a world tour. Like a musician, it went around the world last year and became the most popular viral infection, for 2022. And but before then, it was a neglected tropical disease, and there wasn't really much about it, So, and unfortunately, or fortunately, unfortunately, I would say, Nigeria has a very high prevalence. I mean, the world epidemic, so to speak, of Mpox, kind of would be related to Nigeria. So we need to control, the spread of Mpox here, so that we don't have another world tour of the disease. So we're going to talk about it briefly, and Dr. Oiwo, who has been doing a lot of great work with Mpox in Nigeria, and because he works with IRUA, which is a infectious diseases specialist hospital, he has a wealth of experience and is going to be sharing that with us now. So do you want me to share your slide from here, Doctor? Or you'll share it from your end?
That will be fine. I'm trying to share from my end as well.
Okay, try and see if you can, and if you can't, I can always do that. So I've put Dr. Adetola's email on the chat. If you would like to reach out to him, you can always send him an email and get in touch. Great work he's doing with Zero Noma, by the way, and we're very happy, and we hope that in our lifetime, Noma will be an extinct disease, something that we'll only read about in the history books. That's our ultimate goal by, having such presentations and such educative sessions.
Yeah, I'm trying to share, but I'm having difficulty. So maybe you can share from your end so we don't waste time.
Okay, let me see. I hope I downloaded it.
All right, so while that is being done, I want to sincerely appreciate Dr. Adetula, who incidentally is the secretary of the NMA National Committee on Neglected Tropical Disease, to which I'm the chairman. And I can see from the feedbacks that the audience actually follow the discussion. The pictures were graphic, so I hope the ones we're going to have now won't be more graphic as it were. But the interesting thing is that it's for educational purpose. So I know where Dr. Cole, you can share.
Okay, yes, I'm doing that. Just a moment.
So as we know, assumably, because it's assumed that we are health workers, and as health workers, we have some background knowledge of public health and public health emergencies, and are also involved in public health response in our own area. And so monkeypox, we know it's not a new disease. It's not an infection for 1971. It was in Nigeria, was in 1971. 1958, it was first in a research lab started from. And so in the very recent times, advocates, veterinary doctors and advocates of animals are pushed to extend that, yes, we call it monkeypox, we are stigmatizing the monkeys. So that's necessitated a change. So Mpox is the new name, although monkeypox can still be used within the context of the description till November. Mpox was officially used. Mpox in itself, of course, no, it's primarily a skin-based infection, but can extend to other parts of the body. And the question that we hope to answer at the end of this presentation, get these objectives right, how many of us will be able to know Mpox more, understand the referral, the diagnosis, referral pattern, management, depending on the level of care that we are. And so looking at that, to answer these questions, the following outlines will be used. So next slide, please. So the following outline will be used. So we just talk brief introduction, which I've started. And to help us with this introduction, we have 3 important documents that are used to us in this training. First is the WHO guideline on Mpox. There is the guideline that has been very phenomenal and very helpful for all parts of the world. That's the Nigerian Public Health Response, the Mpox guideline by NTDs. In fact, in one of the reviews that compared guidelines all over the world, Mpox ranked topmost, as it were, in terms of the details in management and all that. Then in recent times, about 2-3 months ago, WHO released the Mpox Atlas. That's the first version. So we'll have those 3 documents to guide us. The question, next slide. The question we would have to deal with is if Mpox itself is a neglected tropical disease. A few publications that called it neglected tropical disease that went from local to global, as Dr. Cole rightly described it. Next slide, please. So if we look at that, we may still, interestingly, Mpox in itself is a disease of neglect. So it's also apt for us to have discussed it here. And so it's important to take note of that. And Nigeria has the highest burden, the highest or largest, the most disturbing burden of the clade 2A of Mpox. And it's good to know, next slide. So those are the 3 documents we're going to glean a few pieces of information from. The next slide will tell us about Mpox, is it a neglected tropical disease or not? So these are publications that I've looked at. That next slide. And so we have, like we have said, Mpox is an infection of the skin that can be contracted by direct and indirect contact, and as well by air droplets. Globally, the incidence of Mpox and the risk of Mpox is moderate, and that in Africa is also moderate. And in very recent times, the whole world was taken by surprise. That was from May last year. But prior to that time, Nigeria has had sporadic cases. The world peaked at about August, while from the NCDC report for 2022, our peak was in September. But we'll talk about that later. Next slide, please. And so if we look at that, someone asked a question at one of the fora I presented, that what's the furore about monkeypox? Yes, it's an infection of the skin that has potential for immense degree of psychological disturbance, either immediately or after, even in the long term, if the immediate term is not handled appropriately. And in various parts of the world, like the clade one that is common in Congo is said to be more severe than the one we have in West Africa. And of course, the one we have in other parts of the world that tend to occupy more than 80% of the global body, they've been tied to be clade 2B. And so we know again that it's a weapon, it's been classified as a weapon of bioterrorism, and all is done globally to ensure that the knowledge that needs to be gotten in Mpox is gotten. And we also know it's a disease of poor people. In fact, Tambo et al. Has actually described it as a poverty-related infection. And we know that COVID-19, no thanks to COVID-19, it worsened the burden of poverty. Next slide. And so we know that over time, concerted efforts have been put into place. And those that are conversant with happenings will see that breaking news that Mpox is no longer a public health emergency of international concern. This was in May. In November 2022, World Health Organization declared this so, but in May it was reversed. But I make bold to say that it is not yet a rule for us in Africa. So next slide. So for us to, if we don't know where we are coming from, it will be difficult for us to know where exactly we are going. And that is why we need to take a small detour, a little detour that will guide us as to where we're coming from. Monkeypox is in the same family with smallpox. And for those of us who are above 45, we can comfortably understand what smallpox looks like. To show the effect of smallpox, there is the god in Yoruba land that is called Shokono, is the god of skin infection, as it were, or skin ailments, or skin infirmities. And so that's there in WHO. That comes to show the effect that traditional beliefs, customs, are important social determinants of health and needs to be put into consideration. And so that's from smallpox. The world was declared free of smallpox in 1980. But a few years before that time, Mpox had started. But of course, not too much attention or little attention was paid to it. So next slide. And thereafter, a few years before that, Nigeria had recorded 3 cases of Mpox. First was in Abia State, in a 4-year-old child and the mother. And it's good to note, of course, that it's been previously known that Mpox is common in children, but no recent epidemiological dynamics is changing. So Oyo State was the next that happened in 1978. And after that, there was a silence, what I call epidemiological silence, that needs to be looked at. Was it that there weren't any reports, or there were reports but it wasn't talked about? Next slide. So the next slide will tell us how it happened that 11-year-old boy came to Niger Delta University Teaching Hospital with this rash that bewildered the registrar, who was on call in the emergency and had to seek for attention. Interestingly, he was my classmate in the medical school. And on that particular day, he sent that picture to me, which I shared with my colleagues, and were able to give some insights that he acknowledged were helpful in the diagnosis. Next slide. So the next slide shows the few reports that showed behind the scene works that were done before that diagnosis was made. And Professor Ogoina, a world-renowned expert and one of the 2 Nigerians in the 100 most influential people in the world, reported how it all happened in Niger Delta University. The next slide, it will show, that next slide will show there's some genomic surveillance that has been done, and we can see the strain. So next slide. So the next slide, please. So we'll see that after that time, after that incident in 2017, there were pockets of sporadic cases until last year. Next slide. So we'll see last year, the world was taken by surprise. And next slide. And this next slide, we'll be able to compare what it is. Next slide, please. We'll be able to compare the picture that we have as of January, between January till this time. If we look at that picture, we'll be able to glean out that the cases have increased averagely maybe by 1,000 per month. And as we speak today, we have over 80,000 cases worldwide. And it's interesting to note that about 101 cases have been observed weekly. The three regions that are most affected are the Americas, West Pacific, and Africa. Nigeria has been reporting cases since 2023. Next slide. And so we'll see that 6 countries have reported increase in the weekly number of cases. In the most recent times, at a point in time, I think as of last week, it was Korea that had the highest increase. But now it's China. So some people will say, why China again? In the past 21 days, 22 countries have reported cases. And it's good to know that of all, the next slide, it's good to know that of all this, the clades have not changed in Nigeria. And genital presentation like we have in the world is not new, in quotes, in Nigeria. Next slide. So the next slide will just show us the various burden of Mpox across various parts of the world. Next slide. That just shows the map. And after the map, the next slide will show us the various degrees, the figures in male, female, and of particular importance is pregnant women. So far, we have had about 58 pregnant women that have been involved. And 1 or 2 reports have talked about transplant center transmission of Mpox. Next slide. So we're coming to Nigeria. In Nigeria, in the whole of 2022, which was the year we recorded the highest, Nigeria had 862. 862. But as of January, 988. But as of January 2023, we also have had some increase. The next slide will show us what the latest report is like. And this is shown with due acknowledgement of the NCDC for supplying this detail. We can see from here that within, we've had a few confirmed cases, both of Mpox and of chickenpox. And we'll see that in April, we'll see a confirmed case. And we know that weekly, averagely, we have reports of such. Next slide shows us the pattern of Mpox over the years. And we'll see that if we look at the figure, the line graph up there, we'll be able to trace that the peak of Mpox is 2017, usually starts around April, May, typically peaks around August, September, and begins to come down by November. And the age groups, generally, the ages between 20 to about 40 years, and that's the active age group. That's the labor force. That is the age group that is energetic, that is agile, that is adventurous. That's the age group that enters the forest to fell trees. And those are places where humans have contact with animals. And that's one of the ways, again, Mpox can be transmitted. Next slide. We'll see that Mpox is more in males than females. From the next slide. And next slide, please. So next slide. We'll see it's more in males than females. And if you look at the subsequent, the next slide, we'll be able to see that pattern that I talked about where we have the peak. Next slide. So the next 2-3 slides will just go maybe 2 seconds per slide. Yes. So we've talked about this. And the next slide is a map. If we look at that map, we can compare in that map the areas that are reporting confirmed cases. Next slide, please. This next slide shows that about 8. Yes. So this next slide shows if you see the red dots, you notice that the red dots are confirmed cases. That's on the right of your screen. Would see the red dots. They are more in the southern part of Nigeria. But from April, May last year, we started to see increase. Adamawa at a point in time was running head to head with Lagos and Rivers. And of course, we know that a few states are yet to still report Mpox as we speak. Next slide. So that's the latest map. This next slide shows the latest map. The yellow are areas that have reported Mpox. Next slide. The next slide shows the various states. I'm from Edo State, and incidentally, I'm the incident manager for Mpox in Edo State. We have reported about 4 cases this year, and the first case was managed in United States. I managed the first case for the year. The patient who presented, interestingly, with rash, with a preceding history of conjunctival involvement. And so that shows some paradigm shift, as it were, that may be in keeping with what is reported in other parts of the world, should we have other similar cases. Next slide just shows up the animals. Next slide, please. The animals that have been where Mpox has been, the virus has been isolated. And we see that there are only 2 animals. Next slide. 2 animals where the Mpox has been isolated. That's the rope squirrel and then the sooty magambi monkey. There are other animals that have been shown to harbor the virus, but none other than these 2 have had the virus isolated in them. Next slide. So the next 3 slides, we just look at the transmission, which have been paraphrased in my previous discussion. But it's important to note that the niche that smallpox left is now being occupied by Mpox, probably because the public health response and the health-seeking behavior towards preventing Mpox or treating Mpox or taking care of Mpox was low. And so Mpox is the most important orthopox viral infection as we have. And we know that if we're going to look at it, we'll see that we can group the transmission risk factors from animals, from humans, from the environment. Environment, agriculturalization, deforestation, contact with animals, tree felling, and all that. Disasters, whereby animals are sent away from their abodes. And so we'll see the age that is being involved here, but dynamics seem to be changing. Next slide. We'll know that there are various models that we want to buzz with in the next slide. But we know of the importance, the fact that the risk of infection increases in HIV infection and other viral infections, as well as skin diseases, skin infections that have been there prior to the onset of Mpox. And these are prototype of them is atopic dermatitis. What's in the local parlance is sensitive skin. So once a person has that, yes, you want to be a little more aggressive with managing Mpox once you have it in there. Next slide. So the next 2 slides, next 3 slides, we're going to do 2 seconds per slide. So we would see that in the next two slides, it's just a very good diagram that just shows the way Mpox evades the immune system of the body, the viral state mechanism, the viral military. Next slide, please. So we would see the paradigm shifts that instead of the number, we have solitary lesions, few lesions, and even lesions at different stages, as against what we know in Mpox, whereby if we have Mpox affecting the upper limb, we're going to have lesions. Next slide. And so it's important to also note that while we have symptomatic Mpox, reports of asymptomatic Mpox and pre-symptomatic Mpox have surfaced, and more work needs to be done in the next slide, please. So the clinical features of Mpox can be viewed. We do know that Mpox is, we say that the incubation period is between 5 to 21 days, some say 30.
The eruptive phase involves rashes at various parts of the body. It starts initially on the face and spreads down. And spreading down would know that it can affect other parts of the body, what we call centrifugal pattern. And if we look at that diagram from NTDs, with the rashes,
look at that diagram from
fever,
NCDC, would be able to see the various percentage, the majority.
Sorry, Dr. Seb, we're having some technical.
Okay, that's fine. That's fine. So the next slide, before the technical glitch is sorted out, an important thing that we need to take note of is the fact that WHO has come up with a Skin NTD, Skin Mpox Atlas. That's Mpox Atlas.
Okay, that's fine.
And interestingly,
sorry, Dr. Seb, can you mute your other device? I think you have 2 devices.
I'm one of the members, and Dr. Cole, who is the lead facilitator of this training, is also one of the members, Dr. Okwo, Dr. Nika Oguleye. And so in that, WHO divided Mpox into 3 different stages: the active phase, the healing phase, and the phase that involves other areas of the body. And so if we have a critical look, when the diagram comes on, we'll be able to see that critical features we look at in Mpox is, one, the pattern of distribution of the rash starts on the face and spreads down. That's for us in Nigeria, clade 2A, though we know that clade 2B in the western parts of the world may differ. But we also know that what we are concerned about is what we have here, which is what we should concentrate on for this training. So typically the pattern of the rash and the fact that there is what looks like the dimpling and crusting, as in recent times WHO called it the donut sign or the pseudopustule appearance. Thereafter, it scabs off. And when you see that patient, too, if you check, if you're able to examine, you see cervical lymphadenopathy. With cervical lymphadenopathy combined with the typical pattern, and patients who live in endemic parts of the world would be able to guide ourselves to say, oh, this is likely Mpox. But that is not to say that there aren't differentials. When we're able to get back, next, Dr. Cole. When we're able to, yes, so when we're able to get the slides back, we'll be able to see those pictures, yes. So that's the WHO Mpox Atlas. So that's active, the active lesions that can affect the male, female genitals, different parts of the body. Next slide. The next slide shows basically would basically show us the next slide will basically show us all that the crusted lesions. And if we look at that picture well, we'll be able to see one of our patients we managed at Irua who had that scab. And then next we'll see resolved lesions, how they look like. And we'll be able to also see that it can affect other parts of the body, the eye, the mouth, and different parts of the body. And interestingly, it can also present like measles in the early phase. It depends on the phase where we pick Mpox. Mpox can start like what we call maculopapular rash, measles-like rash, and it can progress to what looks like scabies-like rash. Then later, that one that looks big, the big ones, may now present. Thereafter, it crossed, that is, yellow coverings come on it. And that yellow covering can later be subsequently followed by lesions that involve scabs. After scabs, the healing phase takes place. And it depends on how it is being taken care of. If it is not appropriately taken care of, the person would be healed of monkeypox. But years to come, there will be post-inflammatory lesions, dark spots, pits on the face. And for those of us who are conversant with the smallpox epidemic, you'll find out that some of our parents who had that, if you see them today, you see plenty pits on their face. That may likely be as a result of not too good management of the Mpox as of that time. Of course, we also know that there are other infections or other skin disorders that can present with pits on the face. Even those that have acne, if it's not well taken care of, you can have those pits on the face. And so there are Nigerian pictures from NCDC from 2019. And in that 2019 picture, we'll be able to see right there, as I see that Dr. Cole is back. So we'll see the active lesions. After the active lesions, next slide would then see the crusted lesion. The patient down there is one of the patients I managed at ISTH, included in the WHO Mpox. Next slide.
Please, I hope this slide it's visible.
Yes, it is. It is.
Okay.
So next slide, please. So that next slide just shows the various ways it can form scales. And if you look at that penis, there's a scar. If you have that on the penis, you can also have that on the face. Next slide. And so we can see that it can affect various parts of the body, the face, the mouth, the eyes. Next slide, please. And this is the measles-like rash at the early phase. Next slide, please. And so this is for NCDC guideline, Mpox guideline, where we see the pattern. And another interesting thing is that when we see the history, person lives in an area where there's Mpox, we see the typical distribution. If we look at the palms, it can affect the palms, which is one of the features we use to guide us. But for those of us who are experienced in managing Mpox, we also have noticed that there are some patients that have those features. You see the palms, you have the involvement, but PCR comes out negative. But that is not to say that that is not a good feature in addition with the history and the pattern of the rash. Next slide. So those are Nigerian patients. The patient in the topmost right, managed in Benue State. You can see that the lesions can be large. Nodules can present as nodules more than 1 cm. And we see genital lesions on the left, and also downwards. That's also one of my patients that I managed. And interestingly, it can also present like acne in that patient, this fair patient. So next slide, please. Yeah, so this work web, we made this publication to guide health workers on need to know information, and in a very didactic form, the few steps that need to be known, the various, and you can see from the diagram there, the different ways it can present. Next slide. So these are patients that have HIV renal transplant. So we can see that the lesions can be worse and more exuberant in them. And there are differentials depending on the various stage that it's picked. Hand and foot disease, hand and foot and mouth disease, scabies, even histoplasmosis and all that. Next slide, please. So this just shows the sequelae of Mpox. It can affect the brain, causing encephalitis. It can lead to death from there. It can cause blindness because of the involvement of if the cornea is ulcerated, it can cause corneal opacity. It can affect the lungs, causing difficulty with breathing and a few other presentations. Next slide. So this is just the case definition, typical history, typical features. We suspect Mpox. When PCR is done, we make diagnosis. But however, WHO added another probable case, a patient who meets the criteria, but as of the time you're seeing, the features basically may not be there, but you can still suspect Mpox. Next slide. So majority of the slides we have now, basic principle is basically supportive. Treat fever, hydrate patient appropriately, because any disruption of the function of the skin causes increased loss of water and even nutrients from the skin. So that needs to be taken care of. Antibiotics should be given as appropriate. Psychosocial support should also be given. Next slide. So treatments available, as it were, like I said, they are basically supportive. There is no globally acclaimed treatment that has been found useful, that has been found specific for Mpox virus. However, there are treatments for smallpox that are being used. Tecovirimat is what is being used all over the world, though I know that we don't have that in Nigeria. But there's also a research that's going on that's trying to look at how to consider the using amongst Nigerians. Then vaccines, of course, are being used, the Janios vaccines and the ICAM vaccines. Special cases of Mpox need special care. Pregnant women, like I said, can be transferred through the placenta, and so care needs to be taken. In children, care needs to be taken in them. Co-infection of Mpox and chickenpox, we know that can also worsen the prognosis. Next slide, please. And so this next slide, those are just the various supportive treatments we want to give. Next slide. If there's fever, give antipyretic, antibiotics for superimposed bacterial infection. Next slide, please. Then you give IV fluids. Then you need to dress the wound. And when you dress the wound, some use normal saline twice daily to take care of it. That's for centers that see patients. When we see patients, how do we report? This is the investigation form. Once you suspect it, the line of information is for you to contact your DSNO. That is the disease surveillance and notification officer in the local government. The DSNO will contact the state DSNO and the state epidemiologist, who would contact the NCDC desk. And samples are to be taken, 3 samples, one from the blood, one as a swab, and the third one is the cross that you pick up. And so this is the form that just shows what you feel there. Next slide. And so adequate history needs to be taken to guide whoever is taking the form. Next slide. And so with this form, this will be sent and packaged in a triple package. And we can see the reporting flow, like I mentioned, the reporting flow from the facility down to NCDC. Next slide, please. So this is just basically the step NCDC is taking massive enlightenment, the needed galvanizing of the influencers and stakeholders to help ensure that the awareness is increased, which is what we are trying to do in this training as well, amongst other things as shown there. Next slide. And so it's important to note that the preventive measures involve reporting cases to the hospital and ensuring that we avoid contact with animals or humans that have it. And it's good to also know as well that for Mpox, the animals can transmit the infection. And this comes about when these animals are not adequately taken care of. Animals that are infected, poor preparation of the animals. And so prevention involves adequate preparation. And One Health approach is important. The next slide will show us that One Health involves experts from animal, human, and environmental health. And it is transdisciplinary. It goes beyond interdisciplinary or multidisciplinary. There is back and forth interaction among the experts. And so that is important to note. Next slide, please. And so the next slide would be able to emphasize again the treatments that are available. Next slide. Psychosocial support, because as of the time this patient has this rash, it's difficult for the patient to come out because everyone would avoid the patient. And there are a lot of misinformation going out there. And the most dangerous of them is disinformation. And so it's important to pass the right information across, which is what we're doing here. Next slide. So we'll see in the next slide that even some world-known media gave a very false information. We can see that arrow. As of that time when they reported this, they were reported more cases than ordinarily is even than what you have in the world. Next slide. And so we are encouraged to be vanguards of the right information. Of course, this publication, we're able to look at Mpox in pregnancy and reviewing the literature. We found out that pregnant women in Africa and Nigeria with the surrounding poverty and environmental encumbrances stand a lot of risk. And so once we have patients who have that, they are not patients you want to play with, because beyond just the mother, the child is there who can get infected through the placenta. Next slide. And then we also see that, yes, this right information can also be passed across with regular awareness publications, like in this publication, which we published about a month or two ago, in didactic ways, in easy to understand ways, targeted for health workers, what needs to be known, understanding of Mpox. Next slide. And so with subsequent slides, we'll now be able to see the various awareness across the world. This is American Academy of Dermatologists also doing their awareness. Next slide. We'll see that in the next slide, the Nigerian Association of Dermatologists has also helped in this awareness. And part of it is this training wherein we are having this awareness. A protocol is being developed that will soon be published. In IFPH, where I work, this is our lab. That's a PCR machine that we use in diagnosing Mpox. But of course, whatever sample we take sample to NCDC, because NCDC, National Reference Lab, is the only recognized lab for diagnosis. So though we have PCR in our center, we are making plans to ensure the adequate synchronization of data for easy recognition and all that are being done. Next slide. And so the various steps that we have employed in ISTH is to ensure that once we have a case of Mpox, we determine whether this patient needs home-based care or not. It's not all patients with Mpox that will be treated in the hospital. This patient was managed from home, and you can see with video conferencing, we're able to do tele-ward rounds, tele-inspection, tele-examination, and this patient did very well, was discharged virtually, as it were, too, because there weren't compelling indication for him to be admitted in the hospital. Next slide. And so, yes, there are researches, clinical trials that are going on, but much of these trials are in other parts of the world. Next slide. A few of these trials, one of them is planned to start in July. 9 centers in Nigeria. ISTH is one of the centers to which I'm the site investigator to look at the way smallpox vaccine can help reduce the severity of Mpox and prevent Mpox in those who do not have it. Next slide. So the next two slides per second. These are just the various clinical trials going on all over the world to gain more understanding of Mpox. Mpox in the sperm, Mpox in various parts of the body. Next slide. And so this subsequent slide just tells us more of the awareness that are taking place. So WHO has released a strategic guideline that guides policy formulators at the state and federal level on Mpox NCDC, WHO, State Ministry of Health, Federal Ministry of Health. Next slide. And so these are the tenets of this strategic planning. And this is part of what we are stepping down in this training. Next slide, please. So, we'll see, like I said, from this subsequent slide, these are the various trainings that that's been done. An appreciation to NCDC and the Diverse Threats Reduction Agency that had this training for us in April last year. And as though, of course, information available to them, which is quite commendable, had prepared the team across Nigeria to prepare. And so from July, the whole world was taken by surprise. But I dare say that Nigeria was not really taken by surprise because the adequate preparation was there. And that is what we are seeing with the reduced number of cases we have now. Next slide. And so next slide would see various public awareness. Next slide. And so that is me facilitating the training on Mpox. This is also a training by Pandora. Pandora is a research agency for clinical trial, an arm of EDCTP, that's the European Drug Clinical Trial Program. And so the Nigerian arm, the PI is the United States, and they've been very supportive and appreciation to them. So this is a training that we had for health workers in Edo State, in ESA Central and Edo Central and Edo North. So this is EPOMA, where we went to the market to enlighten the market women. Next slide. The next slide would see that this is Asaba, the Ogogonogo market in Asaba, where we collaborated with Dr. Ojimba of the Federal Medical Center, Asaba. And so it was very, very enlightening. And we had those feedbacks that were interesting. Nigerians don't want to fall sick. So that was why we went there and we enlightened them a lot more. And we encourage us after this training to enlighten ourselves, enlighten our patients, enlighten our community. Next slide. So next slide would see this leaflet done by Pandora ISTH that was distributed that can also be shared. Need to know information. Next slide. So the roles of health workers. First is to be able to have knowledge, which is what we are doing. That knowledge guides us in appropriate diagnosis, timely diagnosis. We're also involved in policy formulation and advocacy. Research is also part of our work. But of course, we know, depending on the level that we are, we know that on this call, I know there are various cadres from the community health officers, the doctors, the nurses, pharmacists, they are all here. So we have our parts to play in Mpox. And the next slide. So again, we need to remind ourselves of where we are coming from. Next slide. And we need to borrow a leaf from how the world overcame smallpox. And part of it is what we are using. That vaccine for smallpox. The world is using it now to also overcome Mpox. Next slide. So we should learn, when we learn from this, to guide us appropriately. Next slide. Because it's important, a question to ask is monkeypox a sexually transmitted infection? And this is an academic discussion that answers are still being sought for. As it were, now we can safely say it is sexually transmissible. It's a sexually transmissible infection. There are not sufficient evidences to show it's a sexually transmitted infection. Next slide. Of course, in a more technical ground, is a vesiculopustular disease. This one is for a higher level. Next slide, please. So we'll just have a little with what we have seen. Next slide. Is this monkeypox? I'll just take a few moments for us to pause and look at it. And with what we have talked about, the pattern of the rash, the dimpling at the center, and what looks the umbilicus, umbilication. Is this monkeypox? We can just, it would be nice to see our comments in the chat box if we can have that, or even in the Q&A. Next slide. So this looks like Mpox. Then this is this Mpox. We can see that those rashes, there are redness, we call it erythema. And we see that the rashes are of different types. The small, the big, on the same parts of the body. So is this Mpox? Because we need to know what is monkeypox and what is not monkeypox. So it would be nice to know what we think. This is chickenpox. Monkeypox will typically present with rashes of the same size on the same parts of the body. Next slide. Then, is this monkeypox or measles or German, measles, rubella, which of them? So it depends on the history that is available to us and the part of the world that this child lives in. And so monkeypox, the early phase, or even measles. Next slide. We have said that Mpox present like small boys, but they can become big. But we do know that from this slide, can we glean out that this is Mpox or not? We'll see from this, the one that affects the mouth. I know a few of us, if not many of us, have had this before, what we call fever blisters. This is herpes, not Mpox. The one on the other side is herpes zoster. That's the aftermath of varicella zoster virus infection. The patient had chickenpox in the past and the virus hides in the spinal cord. Next slide. So, sincere appreciation to NCDC for providing some of the slides and also providing the situation reports, and then Pandora for their very fantastic assistance. And most importantly, the International Foundation for Dermatologists and International League of Dermatological Society, who have sponsored this 6-month training in collaboration with Nigerian Association of Dermatologists. I thank as well my CMD, Professor Ifedi, for the good support he's been giving Mpox and the state, Edo State itself, and across all states. I know Dr. Cole will want to give a few comments because she is also on the state team of Mpox in Lagos State. Next slide. So while we thank all of this, we want to conclude that Mpox is with us. It is not a disease that is in the air. Interestingly, where I come from in Edo State, in Eastern land, some people have called it OJ and a few other things. But of course, we need to know that it's available with us. We have seen this Mpox. Many of us may have managed it in the name of chickenpox. When we have these patients that have chickenpox-like rashes, send the patients to the lab for samples to be taken that will guide diagnosis. And why do we need to focus on Mpox? Because again, it has a long-term effect on the psyche of the patient. It leaves scars that the patient may live thereafter to regret. So we need all hands on deck. And because again, we are itching close to the time where it peaks. Like I did say, April, May, June, July, we are of that time. So this is why this training is also apt. And I want to say that Mpox is still with us. It is not yet uhuru for Mpox, even if WHO has said that Mpox is no longer a public health emergency of concern, public health emergency of international concern. These are my references from Iroa Specialist Teaching Hospital. I say, Wabulu, thank you so much. Next slide.
So much, Dr. Oyo, for that presentation. I think you did a fantastic job. When I saw 109 slides, I was afraid. But I think we were able to go through it at least in a few minutes and get to the end. Thank you. So, but we just won't have too much time for Q&A, but we'll try and take as much as we can. So let me stop sharing this so that we can see what the questions are.
Question we have here. Yeah. Okay. Somebody, Obina Onoha. Obina Onoha mentioned measles. Yes, I mentioned measles is one of the differentials. And like I said, depending on the stage that you pick Mpox, there are various differentials. At the maculopapular rash stage, measles, and a few viral exanthems. Even depending on co-infection with COVID, you can also have COVID present with exanthems. So like I said, it depends on the stage where you pick the Mpox. Then of course, when it gets visible and it forms umbilicus, I can see Fahad Lawal mentioning molluscum contagiosum. Yes, interestingly, molluscum contagiosum looks like the typical disease when you mention umbilication, but we also know that there are various other infections that can cause umbilication. Mpox is one of them. Even chickenpox can cause umbilication. Histoplasmosis can cause umbilication. Kaposi sarcoma can cause umbilication. So various differentials of umbilication can be seen. Dr. Sunday Origi says, thanks for this wonderful awareness lecture. Can Mpox occur without any other symptom apart from skin presentation? Yes, it's not impossible. In other parts of the world, we have what we call atypical Mpox, whereby the patient have solitary lesions instead of those typical ones we have seen here. Some cases may also have a few other presentations. So it's possible. Have you seen patients with Mpox with psychosis as a complication? I've managed the patient with who presented with irrational talk and irrational behavior. And so for that patient, we thought of encephalitis. Of course, we also take in psychosis. Psychosis is a possibility for Mpox. How highly infectious is Mpox? Is highly infectious by contact. When we have contact with the person that has a secretion from the person, we can contract the infection. I mean, the mode of spread, like I said, is by direct and indirect contact. You touch the person that has it, or the person that has the rash
uses the rash to touch a surface, and you touch that surface, you can pick it from there as well, because chickenpox spreads faster in household. I agree with you. Chickenpox is faster and a lot more aggressive than Mpox. But we also do know that atypical Mpox can have those presentation. And interestingly, Mpox co-infection with chickenpox tend to have worse prognosis. Though some publications have said that the rash burden can be reduced when you have Mpox with chickenpox. But of course, in Nigeria, we know that chickenpox in adults is difficult. Children can manage chickenpox better than adults. The reverse is the case in Mpox, like we have in chickenpox. So I have just a few comments that Django Lawboats, apologies if I didn't pronounce the name well. Since the clinical presentation of orthopox viruses can be similar, what can make one go for Mpox than others? Like I said, yes, they can have similar presentation, like that nodular presentation, those big rashes with central embolization. But the differences are this. Involvement of the palms looks a little more typical for Mpox than for smallpox. Of course, we don't have smallpox again, so we don't expect that anyone would have smallpox. It's been eradicated since 1980. And then there are only 2 labs in the world that has smallpox in them. That is in Geneva and I think in United States. There has not been any reports of smallpox in any other part of the world. Other orthopox viruses, cowpox and others, yes, you can have it in cowpox. But those typical information that we need to look out for, the preceding history, prodromal history of fever, malaria, body pains. Then after that, patient has that rash. And that rash lasts for about 2 to 4 weeks for it to go through all the phases. And so, and when we examine the neck, we'll see lymph nodes. So when we combine the typical pattern of the rash, starting from the face downwards, cervical lymphadenopathy and involvement of the palms, that gives us a higher index for making diagnosis for Mpox compared with other orthopox viruses. What's the role of immunodiagnostic techniques in the early diagnosis of Mpox? Well, there's no convincing role for immunodiagnosis. Yes, in some areas they've looked at immunodiagnosis, antibody. In fact, some works are talking about antibodies, but that has not been proven to be very diagnostic of Mpox. Maybe for research base, that can be looked at. Is Mpox vaccine preventable? Well, not much information has been able to establish that. And I know there are a few cases of, there can be a few cases of reinfection. Mpox, like you say, is still a green area that information still needs to be looked at. In fact, the bulk of the information we have on Mpox came between January to June this year. If you Google the net, and you see a lot of information, but prior to January this year, yeah, you have some, but especially just in areas where Mpox was previously managed. Oluchi says, are there prophylaxis treatment for Mpox? No, there are no prophylaxis treatment for Mpox. All we can do is to do supportive management. Yes, vaccine is good for prevention. And so, like I said, some researches are taking place to look at how injection of the vaccine can prevent Mpox in people who are exposed to Mpox. Thank you for a very lucid presentation. That's my way. How can Mpox be different from molluscum contagiosum? Molluscum contagiosum, like we said, typically it has this flesh-colored umbilication, and typically we really do not have those very large lesions with molluscum contagiosum, though it's not impossible to have those large lesions. Again, would see that molluscum contagiosum, typically the pattern is not the same as Mpox. Mpox starts from the face and spreads down. That is the one we have for us in the part of the world. Basic preventive measures, like I've mentioned, we cook meats very well, especially the bushmeat. We can't say people should not eat bushmeat, but what we can say is we can advise that when we have bushmeat, we should prepare them appropriately. Anybody who has symptoms, animals who have this type of rash, please don't be heroic to say you want to prepare those things. Stay away from those things. And anyone who has the rash, reduce contact, isolation, self-isolation at home if it is home-based care. In the hospital, if the person meets the compelling indication for Mpox, we manage in the hospital appropriately. Which drug is a mainstay? There is no established drug that is a mainstay, but there are experimental drugs that are being used now. Tecovirimat and brincidofovir is being looked at all around the world, but these are just treatment for smallpox. So we're trying to look at how effective it will be for Mpox. Asalo Abimbola, thanks so much for this clarification. Okay, that's just a comment. Can a patient present with both chickenpox and Mpox? Yes. In fact, there are a few reports of Mpox, chickenpox. In fact, the commonest reported prevalence is 30%. That is 3 out of 10 patients with Mpox will have chickenpox. And the patient we have managed at ISTH almost like 30% of them have Mpox and chickenpox co-infection. Though when we now see this, the degree of the presentation of the rash for any of them depends on their viral load. So if we look at their CT value for patients with Mpox and chickenpox, the one with the higher CT, the one with the higher viral load, most likely will have the prominent symptoms, the prominent rash body on the skin. There are other co-infections, HIV co-infection, herpes co-infection, and even other sexually transmitted infections. I think with that, we have answered all the questions. Thanks, Dr. Cole.
Awesome. Thank you very much, Dr. Seb. I think you said it all, and really, we don't have much time left, so we'll just end it there. But I just want to draw to everyone's attention that I've put on the chat the link to the Densa app, to the WHO Skin NTDs app, and also the YouTube page where you can actually watch the previous webinars. And we usually don't share slides because it's a bit difficult sharing slides to the over 1,000 people who've registered, but you can watch all the replay of all the webinars on YouTube. That is available. Thank you very much, everyone. I think we've been able to answer almost all the questions. So thank you, Dr. Adetola, and thank you, Dr. Oiwo, for taking on these two very formidable infectious diseases. But in our lifetime, we hope that we'll see the end of it. At least since smallpox was defeated, then surely Mpox too can be defeated. The world is a bit different now, though, with vaccine hesitancy and a lot of conspiracy theories. But we hope that be able to surmount those issues and be able to face head-on the challenges of these infectious diseases.
Sure.
So yeah, thank you so much. As for Noma, we really must try to prevent such a devastating disease from, decimating, innocent children. And we really must try our possible best to do a lot more education for prevention and early treatment, so we don't see those awful pictures that Dr. Adetola showed to us, that are quite traumatic, even for me as a doctor. So thank you very much, everyone. King Charles is raising up his hand. Unfortunately, we don't have much time. Our time is fast spent, but we can actually and just put it in the Q&A box briefly before we close. But we really need to close now. Yeah, unless we have 1 minute.
Let me just check the Q&A. Dr. Ekechi Amadi, thank you so much. Cutaneous cryptococcosis can also present like Mpox, which can be umbilicated. Yes, that's why I tried to mention like 4 or 5 other differentials of umbilicated rashes. So not only Mpox, not only molluscum contagiosum. Thank you so much for that information. I'm not sure there's any other contribution in the Q&A.
So King Charles, you raised up your hand. What would you like to say or ask a question or make a comment? In like 1 minute, can you do that? Okay, I don't think he's able to do that. Okay, then. So we are done for the day. And we thank everyone for staying till the end. We'll be wrapping up the series next month with more practical application. That's the use of the apps. And, we want to have outreaches in at least 4 places across Nigeria. So we'll be reaching out to people that have indicated interest to being part of that, so we can do some active case searching and practice the use of the apps and all that. Sorry, the app is taking a bit longer than expected to get functional, but before the end of this program, it will be fully functional so we can use it. Thank you so much, everyone. Dr. Nafisa, I don't know if you have anything to share with us before we close.
Nothing. Well done, Dr. Ayo. Thank you very much, Dr. Adetola. Excellent presentation there. I wish everyone all the best, and they should just be patient with us. Let's quickly finish the Densa app so that we can continue the work on the app. Bye, everyone. Have a nice weekend.
I think it would be nice to say Baraka de Salah to Dr. Abdullahi and all the
thank you very much,
everyone. I hope you had a wonderful
the E-rams to everyone else, the E-rams, so that you can just eat your E-meats.
Yes, please do. All right, good night, and thank you, Dr. Adetola. Have a great Great weekend ahead, everyone. Take care.
Yeah, bye.
Bye.